Good morning, dear colleagues. Thank you for coming to this presentation and listening to my projects. My PhD topic is how can we improve the quality of life in postpartum women. My name is Lőrinc Frivaldszky. I'm a resident at the Better Children's Hospital, and I have two projects right now that can help me achieve this goal. The first one is about investigating the efficacy and the safety of esketamine on postpartum depression in cesarean section. And the second one is investigating the efficacy and the safety of immediate administration of long-acting reversible contraception or LARC methods. This is also a systematic review and meta-analysis. I'm going to talk about the first one a bit more detail, and the second one at the end will be also mentioned. So we started this project in September, and we are planning to submit the article this month. So why is this important, PPD? It is prevalent. It affects 14% of all women after childbirth. It is debilitating but treatable. It has multiple features on a clinical side. For example, sadness, sleep disturbances, and suicidal behavior as well. And women who had C-section are especially at risk for PPD. And to this time, we have no prevention, no treatment for prevention. But we have esketamine. It's a version of the well-known drug ketamine, and we know that it has a positive effect on clinical depression. So we have the aim to assess the safety and the efficacy of esketamine in PPD for women after cesarean section. We use the PICO framework to determine the frames of our study. We have a population, women undergoing cesarean section, intervention is esketamine. It is either a one-time infusion or a PCIA, a patient-controlled analgesia that lasts for most cases 48 hours. And the control is the placebo or standard of care. And we have our primary outcome, that is the postpartum depression rate, and is measured by questionnaires like the EPDS, Edinburgh Postpartum Depression Scale. And we, of course, want to measure the adverse effects to determine the safety of this intervention. So we hypothesized that esketamine perioperatively is superior in preventing PPD risk compared to placebo. So we have gone through the systematic search with the search key you can see below with, in 5 databases, and we were able to identify 8 eligible full text with my co-investigator Kincső, and we are done with all the calculations for all the outcomes. I'm going to present some forest plots for you to get some look into what we have found. So my first forest plots contains my primary outcome. These are the odds ratios for postpartum depression. We have used esketamine for intervention, and the population is, of course, women after C-section. As you can see, we have 5 studies here, and it results in a high heterogeneity, but in the end, we have resulted in an odds ratio of 0.32. It means that we were able to reduce the PPD risk with more than 2/3 in this group compared to the placebo. Clinically, it's very relevant, and statistically, it is also significant. The next forest plot contains one of our secondary outcomes. This is the EPDS scores, the Edinburgh Postoperative Depression Scale scores. This is the same population, the same intervention, but we have measured the mean differences in 5 studies with a quite high heterogeneity because of the low case numbers. We have achieved a reduction of 1.42 reduction in the EPDS scores. This score is between 0 and 30. The 0 means like no symptoms for PPD. 30 means the most severe symptoms for PPD. This 1.42 means kind of a reduction, but not that important as our primary outcome. And mathematically, this is not significant. So we have some strengths for this study. that we all used RCTs. For analysis, we have a low risk of bias, and we adhere to our protocol strictly. We have some limitations, of course, because of the low number of cases. Different studies sometimes use different cutoff values and different definitions for postpartum depression, and mostly they use short follow-up times, unfortunately. So how can we conclude these results? We can say that postoperative esketamine can effectively and safely reduce PPD in women undergoing cesarean section. For the clinical side, this can, we can say that we can use this in clinical practice for PPD prevention, and guidelines should consider including esketamine for this goal. For research, we need more studies, we need more RCTs with longer follow-up times, diverse populations, different dosages and different administration methods, and of course it should include women not only with C-section, because PPD affects all women after childbirth, or can affect all women after childbirth. So we have preparing the manuscript for internal review. We have a great progress with it, and we plan to submit it for internal review this week. And our target journal is the Journal of Affective Disorders, as you can see on the right side of the slide. So swiftly about my second project, it is still in its infancy phase. We are comparing the efficacy and safety of the immediate versus the standard administration of the LARC methods in postpartum women. Postpartum period is an important opportunity to reduce the risk of unintended pregnancy because 50% of postpartum women resume ovulation before 6 weeks postpartum, and also at this time point, almost half of the women resume sexual intercourse, and half of these are unprotected. So we see the problem here. We have a possible solution if we insert IUDs immediately after delivery that can result in several advantages. And we aim to assess the efficacy and the safety of immediate postpartum administration of these LARC methods compared to the standard later administration time. We have the PICO framework for this postpartum women, and we compare the immediate versus the standard administration of these LARC methods, and we have multiple outcomes like the satisfaction of the patients, the pregnancy rate, successful insertion, and other safety outcomes as well. For the clinical side, if we have a success in this research, we can provide a safe and effective method for women who are seeking long-term contraception right after childbirth. This is just started, this research, and we are focusing with all our energy on the first one to submit it this month, and we plan to submit the second one also this summer. I want to thank you for your attention with a quote from the Bible: "A cheerful heart is good medicine, but a crushed spirit dries up the bones." Thank you.
Hi, Lőrinc. Thank you for your presentation. You have amazing results. I'm curious about the availability of esketamine in Hungary. I know of a pilot project going on for clinical depression, but has anyone tried it for postpartum depression in Hungary? Thank you.
Thank you for the question. No, there is no use of esketamine for this goal in Hungary. All these studies were from China, if you recognized. So for clinical depression, we use it worldwide, this drug. But for pregnant women, for PPD, it's still a very limited and ongoing research. So, but we hope that soon it will become a prevention strategy. Thank you.
Thank you for your presentation. I would like to ask regarding for your first topic. Why do you have to start the administration of esketamine before delivery? What is the reason for that? Why don't you start it when you can see the sign of depression after birth, giving birth?
Thank you for the question. So if we already have symptoms for PPD, of course we can treat it. We already have the strategies for treating depression. We want to prevent it. So that's why we give it
before.
during delivery, like after they clamped the umbilical cord, that's when they gave the esketamine. And we want to prevent the symptoms, we want to prevent the negative effect on the child and on the mother of PPD. That's why we or the studies administered it so early for prevention.
Thank you, Lawrence, for your presentation. I have one question, because usually when we suggest using a drug, we investigate both efficacy and safety. So my question is, do you have any data about the adverse event of this drug?
Yes, I forgot to mention it during the presentation, but we also calculated and pooled odds ratios for adverse outcomes, and we can safely say that there were no outcome that was significantly higher rate in the intervention group. So, and this correlates with the literature that although it has some adverse effects, they are not that serious and not that prevalent. So we can safely use this drug for this cause also. Thank you.
Okay, I have one question. How much was the average follow-up time regarding to your first project?
The average follow-up time was 4 weeks, and it is short. Like PPD can emerge even later than 4 weeks. So that's why we advise to conduct more RCTs with longer follow-up time, because there were some bit longer, like 6 months or even a year, but we need more in this topic as well. Thank you.
Thank you.
Thank you for your presentation. My question is also about esketamine. Can you talk about the difference and the similarity of that and more currently used antidepressants, or the effects of that versus psychotherapy? Has anything came up about this during the literature review?
Well, you mean for postpartum depression prevention, or just in general for the drug?
Or generally.
In general. So esketamine in psychiatric use is used for the treatment-resistant depression. So if other conventional therapies like psychotherapy or conventional antidepressants are not successful, that's when they can recommend using esketamine. It is mostly intranasal administration, by the way. So this is for the most serious cases in psychiatry for depression.
Wonderful, thank you.
Thank you.
There is any contraindication to use esketamine?
Above the most obvious one, like the allergy for the drug or known complications during the pregnancy, there were no exclusions or contraindications for this drug in this case.
Thank you.
I have a question about your second project.
Yes.
You mentioned to use administering IUDs right after delivery. Does it mean you use it or take it in the delivery room, or during the 6-week period until the first follow-up visit, or when?
In this case, they are administering right at the delivery. So after the baby arrived, that's in
at the
time
delivery room.
Yes, yes, basically there. Yes.
This is a bit strange for me, but can be work. Okay, so thank you.
Thank you.
I have one question. Which cares were described as placebo in the studies?
Basically, if they used a one-time infusion of esketamine, they used saline for the infusion, so it's placebo basically. If they used esketamine for this PCI, for this longer analgesia, then it was administered together with some other painkillers, and in this case, these painkiller, the different methods for used as comparison for esketamine.